This is Selma Schimmel in Chicago at the annual ASCO meeting, and we are now joined by Dr. Heinz-Josef Lenz, Professor of Medicine and Associate Director, Clinical Research of the Catherine Balakrishnan Chair for Cancer Research at USC, the University of Southern California, Norris Comprehensive Cancer Center.
Good morning, Selma.
Good morning.
I'm very excited to be here.
Are there any major treatment highlights that came out for colorectal cancer at this meeting?
So the oral session where the most important new data are discussed and presented showed very interestingly that when we treat with bevacizumab in first line,
Which is Avastin.
we can maybe continue with either Avastin or other anti-angiogenic drugs. So we have aflibercept, bevacizumab, and regorafenib. All drugs which target tumor blood vessels. All three drugs and trials showed a positive impact on overall survival in second and third line. So one of the messages is that to really target tumor blood vessel formation is important beyond the first line treatment. The benefit we can discuss is 1.4 months enough? Should we be satisfied with 1.4 months? And the answer is clearly no. So how do we do that? And I think the key, we know some patients will benefit substantially and others will not. The 1.4 is a median. Who wants a median? Everyone wants a treatment which works for them, not for a median population. I think that has to be the challenge, and our molecular understanding should be able to do smart clinical trials to figure out who should get continuous treatment with anti-VEGF therapies.
What's really different this year from last year?
I think you can see a wave of molecular classification. We saw in the discussion from Europe, like in breast cancer, we have 5 subgroups, never known before. Should we treat them the same? Makes no sense. But what is the specific treatment for these 5 subgroups? I'm sure we will see that either next or the year after in the plenary session. That is where the advances, where you get very excited. It's not there in the clinic, but it will come. You can see the whole urge and move in this direction.
The other area of real profound interest is the role of the pathologist.
Yes. So I think with our more and more sophisticated technology, tissue handling is critical. Okay. Sometimes we need fresh frozen, sometimes we need paraffin embedded. But if a tissue sits for 3 hours on the bench in the OR, your specificity and what you can do with the tissue is going out of the window. And I think pathologists need to be part of the development of this test, that they know how critical this is.
The other thing that I really have learned at this meeting is that a patient may have an initial molecular analysis of their tumor, but along the way, they may need to have a second look, and maybe you can elaborate on that.
It's a very good point, and I think that is what is missing and lacking in our understanding. We usually take the primary tumor at the diagnosis. Patients are treated for 1, 2, or 3 years, and treatment may fail, and we use the molecular makeup from the past.
Right.
The exposure to treatment, of course, will have an impact on the tumor. Some cells will die because they're sensitive, and others will not. So the cells who survive will be not the same in the original diagnosis. So I think in the research community, the scientists and physicians recognize that we may need to do an additional biopsy to see what molecular changes happened. Some will have gained some of the functions and some will have lost. And I think that is the misunderstanding of our new drug development, because we combine new drugs here based on a molecular diagnostic here. And then we're thinking, why did it not work? Well, what happened here may explain all the differences.
I think it's one of probably the most important parts of our discussion here for patients to really hear that.
Yes. You know, I think it's very funny. You know, about a year ago or 2 years ago, I tested KRAS and I resected a patient. I sent it back to the same diagnostic lab and they said, you don't need to do it. You did it about 8 months ago. I said, yes, I do, because I don't know if it changed. So we always so convinced this is what we need and we don't need to re-challenge.
Dr. Heinz-Josef Lenz, Professor of Medicine and Associate Director of Clinical Research at the USC Norris Comprehensive Cancer Center, the Catherine Balakrishnan Chair for Cancer Research.
Thank you very much, Selma.
Thank you, Dr. Lenz.